It's a severe disease. But you can miss it on chest radiograph. And the patient is coughing, sincerely, the patient is very sick. But when you do chest radiograph, you miss. It's normal. I also show you the importance of facial CT chest. Okay. How about MRI then? MRI is very limited. It has a limited role in respiratory system. I told you about this. It has an artifact from large volume of air in the lungs. It's preferred. CT is preferred than MRI for CT in some cases. MRI can be preferred than CT scan in some cases because of the ability to obtain image in the coronal and sagittal plane. And remember, I told you that from the scanning, MRI can make both axial, coronal, and sagittal immediately, automatically from the machine, from MRI machine. But CT scan, you just do axial and you do the construction afterwards on the other computers. Okay. Like I say, it can give and in chest diseases. Indeed, unless, for example, in mediastinal masses tumors, because we remember MRI is better in soft tissue differentiation, you can very rarely say, let us do MRI and see if you can differentiate better these tumors of the mediastinum soft tissue of the chest wall. Otherwise, CT is preferred for chest diseases. Okay. Indications for chest MRI, evaluation of mediastinal masses, as I told you, suspected pancreas cyst. Pancreas tumors is tumors at the tumors and at the apex of the lung. Supravelar cover syndrome, staging of lung cancer. When CT suggests inversion of the heart, maybe another reason, but the heart is still part of the mediastinum. Some MRI can be used, by the way, that one I insist. When you want to do MRI, cardiac MRI is better than CT scan. In terms of cardiac as soft tissue of the heart, MRI is better than CT scan. But the vessels, maybe chest wall cause soft tissue, the diaphragm cause soft tissue, you can say let us do MRI, but very rarely. But only this one, evaluation of mediastinal mass, but also in some special cases. So I thought the aortic dissection, CT is better. I know. But MRI can give still diagnosis. It is maybe here when you have an MRI machine without having a CT scan around, maybe. You can still say, instead of sending the patient for 50 kilometers, let us do MRI for these cases, okay? Evaluation of mediastinum and highly in patient with allergy to iodinated contrast media. Okay, maybe another reason is when the patient has a contraindication to contrast media used in a CT scan. You can now pass to MRI and say, because you cannot do CT, let us do MRI. Okay? Is it clear?
Yeah, it's clear.
Yeah. So this is how MRI by the MRI machine looks like CT scan. By looking at them from far, they look the same, but they work differently. Because remember, CT scan is it's used X-rays, but for MRI is just magnet. Okay. There is no radiation in MRI machine. But there are some, like this is an example of how MRI is very good in soft tissues. CT scan cannot give this kind of MRI, image of the heart. Left atrium, right atrium, ventricles. Look how the muscles of the ventricle look very nicely. You can't have this in a CT scan. But you need to see the muscles of the heart in some special cases, not just all the disease of the heart. No, in most of the cases for the heart, we want to see the chambers and valves. Okay, and you can see chambers and valves here. MRI is not that good. Okay. For the lungs, look how, okay, this is an MRI of the chest. Okay, when you see very well, this is T1 a sequence, one of the sequence called T1. The muscles are very well seen, the bones can be seen, the liver, the spleen here. But for the lungs, you can't see much. Imagine. You can't see much in the lungs, but in the chest wall, you can see. That's the reason why I say if you suspect any chest wall mass or mediastinal mass, MRI can be good. Can you still diagnose any disease? But for the lungs, it is somehow not indicated. Okay. So for ultrasound of the chest, people out of radiology think that ultrasound is not for the chest. But let me tell you, it is ultrasound very useful for the chest, especially before even going into details of what is written here. You knew that ultrasound can help in diagnosis small pleural effusions or in any small pleural disease, and even for children who have a very thin chest wall, you can still diagnose some diseases like pneumonia on ultrasound of the chest, of the lungs. We do, by the way. And it has advantage if you can diagnose pneumonia without irradiating the patient, the children. So why not using ultrasound? Why doing CT or X-ray? Why do you have ultrasound in the department? Okay, so ultrasound can identify septations within loculated collections, septations within spaces. That's the reason why a radiograph cannot show it. Even CT may not be able to show the loculations, the septations, but ultrasound can still show. And when you see the septations, now it will narrow the differential diagnosis to tell you that this is maybe this disease, not this one. Okay. Number two, ultrasound can be used for guided thoracocentesis. By the way, in most of the cases we use ultrasound to use the thoracocentesis for the patient who have maybe some pleural effusions like in PMR or pleural effusions or some pneumothorax or something, especially when fluid collection is small or loculated. Guiding percutaneous needle biopsy of peripheral lung, pleural, chest wall lesions. Evaluate thymus and mediastinal masses. Yeah, you can still see the mediastinal masses and thymus on ultrasound of the chest. Distinguish cyst from solid masses. I remember ultrasound is the best one in distinguishing the cystic from solid masses. Even for other part of the body, like breast or any other part of the body, when there is a mass seen on the other modalities, like especially chest radiograph, you use ultrasound to know if it is cystic mass or solid. Mediastinal biopsy can still be guided by ultrasound. Endoscopic ultrasound demonstrates lymph node and other masses adjacent to esophagus. Endoscopic ultrasound, remember I told you about endoscopic ultrasound, you see. So those are the indications for ultrasound of the chest. This is an example of this also we do when you are doing abdominal ultrasound. It is very, very easy to diagnose a pleural effusion. Like this case, This is abdominal ultrasound where you have, this is the liver. This is when you return a liver. Now, this is now the diaphragm, hemidiaphragm on the right, hemidiaphragm here, the white one. And now the prospace is this one. That prospace now has some dark or not, it's fluid. It has some fluid. Okay? And now you say that there is pleural effusion here. Okay? That's are you with me?
Excuse me, sir.
Mm.
I haven't understood about siltations. Does it mean siltation?
Those are substations are they are like I can call it very simple, like the lines within fluid collection. Those are recepted within the fluid collection. It means that the fluid has been there for some time. It means that it can be even amphiema, and it can narrow the differential diagnosis. Say that is maybe TB or something else, not just fluid, clear fluid as in proeffusion, cardiogenic proeffusion. Yeah. Okay. Okay. Hello. Can I continue?
Yes.
So another modality for the chest is what you call radionuclide imaging. This one is full, and we still do this radionuclide. Remember that we don't have nuclear imaging in Rwanda. Very soon we will have one. Physiological function of lungs. Remember that nuclear imaging in general, it's more functional than just anatomy. And some techniques used in evaluating the disease of the text. We have lung perfusion. You call remember ventilation perfusion in the case of pulmonary embolism. When the CT scan maybe cannot diagnose this, I mean, ventilation perfusion or nuclear imaging is more sensitive to embolism. Positive emission for cancer, for site inflammation within this type of these guys 60 some 111. Those are different in of radionuclide or nuclear imaging. We use no, it's like they are like a radiopharmaceutical or tracers. Radiopharmaceutical, the amount of used in imaging. And those no are specific radiography. Okay, that is one of the example of radionuclide imaging of the chest. Okay, I'm done with the radionuclide imaging of the chest. That's what I can tell you in summary. Just I want you to have an idea about what's that, how can it be used in chest. So barium swallow, you remember when you say barium swallow only, why barium swallow? Because you remember I told you that barium swallow is for the esophagus, okay, to check how the esophagus looks like. Barium swallow, you give barium contrast orally. The patient can swallow it. As the patient is swallowing it, you can follow it fluoroscopically. On fluoroscopy, you follow it, you see if there is any narrowing, any stenosis of the esophagus, if there is any filling defect. Remember, I showed you the esophageal varices. I remember I showed you esophagitis. I remember for the first lecture how you can diagnose it on barium swallow. Okay. But they say investigation esophageal disease, authority responsible for pulmonary disease, like achalasia, the irritation of the esophagus can be seen. And because of that, it causes now aspiration of the content of the esophagus, a posterior esophageal putsch, esophageal diverticulum, gastroesophageal reflux. These can be diagnosed with barium swallow, demonstration of aortic arch anomaly, vascular ring and slings that is compressing the esophagus. You can see them on barium swallow. Demonstration of tracheoesophageal fistula, very well seen on swallow, and esophageal leaks can be seen on barium swallow. Okay, so barium swallow is very important to use for diagnosing some different diseases of the chest. Like this is an example of oblique esophagram. Esophagram is just one series of barium swallow where you can follow. Can you see this is the trachea? Remember the trachea is behind, is posterior to the esophagus. You can see the esophagus very well from up there, from the mouth to the gastroesophageal junction, because this is the fundus of the esophagus. The gastroesophageal junction is here, it is here. And you can follow it. If there is any stenosis, if there is any filling defect, you can see it very easily. Because the way you see this, you are seeing it in real-time examination as the barium swallow is flowing through the esophagus. You can see it, okay? Okay, is it clear?
Yes.
So this is an example of, this is an example.
Yeah.
Yes, clear.
Yes.
Is it we use the barium swallow with which guided the imaging? Which image do we use? I don't remember.
Fluoroscopy. Fluoroscopy.
Okay, thank you.
Tewandavuga nihuta nabivuze mu kanya cyangwa manetwork yacu ameze nabi. Something else I wanted to tell you is this is an example of contrasted CT pulmonary pulmonary angiography. Can you see that from like this image? Can you see that you can see the white now? The white color is contrast media you have given into veins, intravascular and contrast media. Okay, when you follow it very well, there is a filling defect on this edge. Why this? Can you see a filling defect within the vessels? The dark filling defect. Can you see them?
Yeah, we see.
Those are thrombi. Those are thrombi. Pulmonary. You remember this is a. I know you don't know the anatomy. No. Let me tell you why this coming in. Why is it coming? Can you see this coming in? Eh? There is this content that's coming in the image. I
Yeah,
don't know
we
why it
can.
comes. You can see it. Why is it coming?
Not
What can
where.
I do?
You can see.
What can I do? Okay, I know how to punish it. Listen, this is a feeling defect. Huh? This is a feeling defect. This is ascending aorta here. Okay, the ascending aorta. This is pulmonary trunk dividing into right pulmonary artery and left pulmonary artery. But in this pulmonary artery, especially the left one, there is a feeling defect, dark feeling defect, dark feeling defect. That is surrounded by the contrast media white. So this is a thrombus. This is a thrombus. This is a sign of pulmonary embolism. The same on the left side. It's even clear on the left side, on the left image or right image for you, my friend. Okay. You can see this feeling defect, the same feeling defect in both pulmonary arteries, but they are surrounded. When they are surrounded, the feeling defects are surrounded by the contrast. We call it acute pulmonary embolism. When it is completely filling the vessel, the artery, it now becomes chronic. You can differentiate and see this kind of acute from chronic pulmonary embolism. Okay. And when we we change the image into lung window, we can even see some opacities in the lungs, what you call Hampton. Hamptons. You know the signs. Some opacities are the sign of lung necrosis, because if there is no blood supply to one of the part of the lungs, now that part of the lung will die, like will necrose. Okay. Is it clear here? Any question? I go to the next one. Can I go to next slide?
Yes, you can go.
Hey, I'm done. Why not? That was the last for this lecture. That was the last slide. So if there is any question remember this lecture, as the second lecture, it was about chest imaging overview. I was just touching on it from different modalities in imaging, but for the chest. So any question?
Lecture akantu
Kabuki.
hano ventilation perfusion centigrade. Yeah, you can just while clarifying that
Bafata
somehow.
umurwayi iyo batekereza ko umurwayi afite pulmonary embolism. Okay? Okay. Bamuhereza twahita ko ari contrast, ariko ubundi bazita radiopharmaceuticals. Urabyibuka ko ariko babyita. Iyo ahumeka, sibyo? Arayihumeka, iyindi bakayimutera mu mutsi. Iyo rero muri lungs habayeho defect, ubundi hagombye kuba hari homogeneous hose muri lungs, ariko bagasanga handi yandi yahumetse byakwiriye hose muri lungs, ubona ko ari homogeneous, harasa hose. Ariko wareba ahandi bamuteye mu mutsi ugasanga hari ahantu umuti bamuteye utageze, meaning hari ahantu utageze, byanze bikunze byaturutse ko hari thrombus, kubera yuko nta mpamvu nimwe, kandi iyo wahumetse yo muri bronchi nta kibazo gihari, imyanya y'umuhumekero nta kibazo gihari kuko biri homogeneous, ariko aho batera amaraso imitsi ugasanga harimo defect. Nibyo bita muri diagnosis bayita mismatch. It is mismatching, the two images are mismatching. Okay, tumenya ko the vascular, the issue is vascular.
Okay, I get it.
Any other question before you go to another one, or I give you some 10 minutes to 5 to you? Turacyafite iminota ntabwo nyipfusha ubusa. We have more than 30 minutes. I don't want to, because turacyafite ibintu byinshi byo kwigana. So we should use this 30 or 20 minutes, or I give you 10 minutes to rest a bit, but don't go far. It's just 5 minutes at the,
Yes.
10 minutes,
Yes,
you
sir.
come back.
10 minutes you come back. Tukoresha iminota
Yeah.
30 isigaye.
Yes, sir.
Okay. Hello. Hello.
Yes.
Yes, lecturer.
Do you think just we have 20 minutes to go? Do you think it is useful or we stop by here by coming at 2?
Yes, we can stop by here and come by
At 2,
2.
exactly. Yes, at 2 we start.
Yeah, exactly.
Yes.
Oh,
Yeah, at 2.
Okay.